Hi, everybody, and welcome. Today, I have a really special guest. I'm excited to welcome Dr. Lonnie Simpson to talk about all kinds of things on bone health. I am a big fan. Dr. Lonnie was one of the first voices when I was seeking information that I felt like I could really trust, that I could build on from her book, the No Nonsense Bone Health Guide. So Dr. Lonnie has over 30 years established herself as one of the leading experts in women's healthcare and osteoporosis. Through clinical experience and a multidisciplinary approach, she has educated thousands of clients and professionals. She's a chiropractic doctor and certified clinical bone densitometrist. This is from the International Society of Bone Densitometry, awards the CCD certification to those who've demonstrated through exam a mastery of an approved body of knowledge in osteoporosis diagnosis. I share this because this is an incredible designation to have, and this is valuable for how we're going to discuss DEXA scans today. And Dr. Simpson was the first alternative doctor to be awarded this certification. She is co-founder of the East Bay Osteoporosis Diagnostic Center since 1994. Best-selling author of Dr. Lonnie's No Nonsense Bone Health Guide, and no nonsense is it. It gets right to the source. And she also has a weekly masterclass with live webinars with current research and interviews with experts in the field, which I deeply appreciate. Dr. Lonnie, welcome to the Brickhouse Bones family.
Oh, thank you, Lisa. Really fun to be here with you. Yeah, I'm a fan of yours too. So this is a shared experience here.
Oh, wonderful. Thank you for making time. And I really mean that. You know, it's a minefield of information. When somebody finds out they have osteoporosis and they're looking for reliable, factual information that doesn't take them down a million rabbit holes, you were a light in the tunnel for me. So thank you for your book, because I know it takes a lot of work to write a book.
Actually, I've got two of them out, and the last one, a lot of it's about vitamin D and how vitamin D and the kidneys and the parathyroid work together, and it's still really about bone as well. So yeah.
Is that the no nonsense Sun Health Guide?
Sun Health Guide. Yeah.
Yes. Yeah. Very good. Very good.
And I will not be doing a third because my partner divorced me. So
that's how much work is involved, and really
it's a lot of work. It's a lot of work. Yeah.
A good resource there, but that resource lives on, which is excellent. So in your book, you talk a lot about errors that can occur in DEXA, and that's a common thing to see in some of these social media sites. People want to dismiss their DEXA scan because they say it's full of errors. But we know that we can get an accurate test. What are some of the things that patients can do to decrease the risk of an error, or even detect that there might be an error? That's a big question, I know.
And it's a great question, and it's a tough one, honestly, because I am an expert at it. I've been doing it for 30 years. I had one of the first bone density machines back in 1994 when they first came on the scene in 92. And my DEXAs back then, bone density machines, were actually excellent. Why? Because I read the manual. I mean, it's not like this hasn't been out there. In the International Society of Clinical Densitometry saw all these errors happening because why does it happen in the first place? It happens in the first place because doctors actually do not need to be trained, nor do their technicians. So the problem with that is, unless they're willing to really put their time into learning, they're not going to know or read the manual. They don't do it. And a lot of times, a lot of these centers, the imaging centers, will put make the technicians do like 4 in 1 hour, DEXAs, and you can't do it right that way. So why is it? It also goes back, and I just want to give this information. A lot of it also has to do with the fact that Medicare doesn't pay much. So, and I've talked to so many people with imaging centers. I mean, they pay like $50 or something like that. So there's no incentive to send your technician or yourself to pay more money to be trained. Now, I'm kind of I want things done right. So I paid for it. I did it. I mean, I think everybody should do it. I mean, imagine if we had a mammogram and the technician was not trained. I mean, really, this is just totally absurd that it's still happening. It was happening, back 30 years ago. Now, that said, bone density is still the best thing out there when it's done correctly. And in the back of my book, I have images,
Hmm.
which I highly recommend my book because even though it was done 10 years ago, bone density part hasn't changed. There's, a whole chapter on labs. There's a chapter on alternative things that, frankly, I still think the same thing about. So there's not a lot I would change. I would change certain things like the amount of vitamin D I recommend, which is frankly around 2,000, not 5,000.
Hmm.
So there are things I would change, but I'm just saying as a guide to have a good baseline of understanding because this is a new language and I want people to become what I call bone literate.
Right.
So that would help. And also, here's a big one. If you have had a previous bone density, even at the same facility, because a lot of times you're going to go in that facility and the different person may be there.
Hmm.
They're supposed to bring up your previous images. They're not supposed to apply new lines. They're supposed to use the original template. They don't do it. So bring images in. So I always say to people, when you get your bone density, get the images, get the CD that they give you, or sometimes they'll give you a printout.
Hmm.
And the printout, it should look like little x-rays, just like in my book, little x-rays with lines that you can see. They copy it on a machine that won't show those lines. So if you bring those images in, my doctor says use the same template. Or if it's in a different facility, get it as close as you can.
Hmm.
We want to have people on the same exact bone machine, bone density machine if possible,
Hmm.
or the same, like say for instance, you started with the Hologic company. There's two main companies, and I'll stop
Right.
talking about this part. There's Hologic and there's GE Lunar. So you want to stay with the same exact machine if possible, same model number.
Hmm.
Okay, you ask them that. And if they can't, if you have to go to a new machine, try to get the same type of machine. So Hologic to Hologic or GE Lunar to GE Lunar. If you're
Okay.
going from completely different machines, that's much more difficult to get a good bone density machine, bone density comparison. You really
Comparison
can't.
side
Yeah,
to side.
yeah.
Yeah. That's just great advice. So this is different than just the radiologist report or whoever read the report. That you're talking about the full report that has the images, and they can take that in for their second DEXA scan because you can say this is the template I want you to follow from before if they
Yeah,
haven't done
you
that
can just
because
look it up.
oftentimes they haven't done it.
It's probably faster for them not to look. I don't know what it is.
Yeah.
It's just incompetence on so many levels. But that said, bone density is still the best thing. A lot of people are doing the REMS technology.
Hmm.
You've heard me talk about that. I've made two videos on that. The question is it better?
Hmm.
Is it equal? My answer to that is no. And I've had a lot of experiences with it. I can't go into that now. That's a whole other interview.
Hmm. Yeah, that would be
But
another whole interview. Yes.
no, it is. I actually had at one point, Lisa, 25 cases. They came out to me. Everyone wants my, approval, if you will. They were willing to give me one of their machines. Did I want it to work? You bet I did.
Yeah.
I wanted to feel this is going to work. This is going to be better than bone density.
Hmm.
But when I compared it to a well done bone density, they were all over the map.
Hmm.
So no, they're not better. There are studies. I mean, 90% of it is just BS, honestly. It's not really related to what they're doing. They're actually using studies that were done in bone density machines, not REMS. So
Well, and that's what's confusing is trying to compare it. It's apples to apples, and it's really not.
it's not.
It's not.
It's not.
Um,
And here's the thing, let me just say this. The errors that can happen just because that can give a false reading in terms of in the spine, for instance, is arthritic changes.
mhm.
That'll falsely elevate the bone density.
With a DEXA.
And bone density, yeah, and the
Yeah.
DEXA.
Hmm.
And scoliosis, significant scoliosis can do that. Sometimes I can read one or two in terms of the vertebra on a scoliosis case. And that's still, we want to be able to have four diagnostic, but if we don't, two is fine, but one's not. So, and the spine, but see, here's the thing. Let's say the femur has a negative 2.5 T-score. Now, that's the borderline of osteoporosis. That's 30% less bone density than an average 30-year-old. Let's say we have a negative 2.5 in the femur, the hip, the hip bone.
Hmm.
And in the spine, we have a negative 1, which appears to be better.
Hmm.
Okay. Well, let's say that person's 60 years old. I already know what happened, Lisa. I already know that that's probably arthritic changes.
Hmm.
And what will I do? I'll order x-rays to see because we want to understand if there's a big difference. Now,
Hmm.
here's what's typical, a big difference between in the other way, that the spine is, let's say, a -3. So that's 36% less bone density than an average 30-year-old. And now let's say that the femur is a -1. Okay, that's 12%.
Hmm.
So there's lower bone density in the spine than the femur.
Hmm.
People say, "Oh, that's inaccurate." No, that's what I typically see in a 60-year-old, let's say.
Hmm.
Why? Because they did not take hormones. I'm not saying everybody can take hormones, but I am saying that women will take typically a huge hit in terms of bone density, in terms of loss, because they're not taking hormones. Now, if they were working with you and they couldn't do hormones and they're really, really buffing up, seriously buffing up in terms of exercise and bone building types of exercises,
Hmm.
it can minimize that with a good diet. But I mean, there's so many factors.
So many factors, right?
Yeah.
So, so is that a relationship to the metabolism of bone and the turnover of bone? Is it different in the spine than the hip? And is that why you would consider it normal to see loss in
Good
the spine?
question. Well, the spine, we lose in the spine first because that's trabecular bone.
Hmm.
Also, we gain in the spine first on medications.
Hmm.
Now, in the femur is primarily compact bone, the harder outer shell of bone.
Hmm.
And so it's just different. So the femur neck is primary compact bone. And we don't tend to lose that in terms of age-related loss, which is about 0.5 to 1% a year, until women are about 65 and men about 70. So that compact bone, but let's say someone's not exercising and they're just kind of walking around and they're going to lose in that area too, but it may start sooner. So I'm just saying average age is around 65.
Hmm.
But that's why we see loss for women, especially in the spine first. Now, the total hip can reflect. So it can kind of reflect, some of the trabecular loss at menopause because it does also the total hip measurement has not only compact bone but uh, uh, trabecular bone.
Hmm.
Now, here's the other thing, though. What I do, I always order the forearm.
Hmm.
Why do I always order the forearm test? Because the mid forearm is almost all compact bone.
Hmm.
The distal radius here is trabecular bone.
Okay.
Now, I can't like compare 1 year, like say on the ultradistal radius. I can't compare that in terms of gain or loss or anything, but I don't care. It gives me another sense of all the data I can get on a
Hmm.
set of bones helps me. So that will give me reflect a little bit about what's going on in the spine, possibly.
Hmm.
They'll be often the same, actually. And the mid forearm, that should be pretty good. That's compact bone. Because remember, I said that doesn't tend to go
Hmm.
till later. Now, what if it's really, really low? Well, sometimes there's lots of different reasons, but the primary reason would be primary hyperparathyroidism. And
In
that
the
tends to
forearm,
go
really?
after compact bone. Yeah.
What about, I mean, we don't walk on our hands. Is it that we don't have as much weight bearing? Would you
Well, yeah,
see?
yeah.
Yeah.
And women, well, let's say women, men not as much, but women who are not really active with their hands, like out
Pushing, pulling,
gardening,
carrying
pushing,
loads.
pulling,
Yeah.
kneading. Boy, but think about making bread.
Hmm.
I mean, how good that was for the forearms. So yeah, I mean, in those cases, and as people get older, men and women, their forearms just go in terms of their bone density. And those are the first fractures we see. So
Hmm.
in a woman's 50s, typically what we start seeing is an uptick in wrist fractures,
Hmm.
forearm fractures, but also metatarsal fractures. I mean, we just start seeing them.
Hmm.
Men, we don't see a typical uptick in fractures in the forearm because they have bigger bones. Men in general tend, although it'd be interesting to see what the millennials are going to be doing and stuff like that in years to come. But yeah, so it just depends. There's so many factors.
Oh, yeah. Yeah.
Bone is highly complex.
That's the challenge. So let's circle back to you have someone that shows minus 2.5 in their hip, but their lumbar spine is -1, and you're suspecting that that just doesn't always match. So there's likely an arthritic component. So you order an X-ray, and the X-ray shows degenerative changes consistent with arthritis. How does that change how you make recommendations to that person?
Well, again, it depends on lots of factors. Brings up another test that I like to do, the trabecular bone score.
Yes.
The trabecular bone score is another thing that can be done on a bone density test, as well as a vertebral fracture assessment, as well as a body composition test, which a lot of the athletic, warriors use it. In fact, I was on a table that Steph Curry used, so recently to do mine. So
Very cool.
the trabecular bone score is added information. Not all centers have it, but it gives us a sense. So the strength of bone has to do with two factors. Certainly the density, right? So we want dense bones, that inner working of the bones. Where do I have my example here?
Yeah, dense is how much bone there is.
Yeah, dense is how much bone. Okay, so this is the trabecular bone inside. This is a little chunk of the spine, right? And that's the trabecular bone. And then that outer hard cover is the compact bone. And a lot of times on X-ray, you barely even see the compact bone. And one of the ways they see osteoporosis on X-ray is it's pencil thin. But you have to have about 40% loss for that to actually show up as the definition of osteopenia on X-ray. They don't use the term osteoporosis. So if they see osteopenia, that's actually osteoporosis, pretty advanced probably.
Right. So it has to be pretty advanced just to even show up on a plain X-ray.
That's right.
Yeah. Yeah. Interesting.
But let me just say one more thing about that trabecular bone, because you pointed out it's the density, but it's also now, okay, so beyond density, it's how well that bone responds to impact. So the flexibility, if you will, and those two things, the density and the bone quality, make our bones strong, because there are people who have osteopenia, meaning just low bone mass, who are fracturing easily because their bone quality is not good beyond the density alone.
Right, right. It's how those bone's organized, whether it's a strong, flexible structure or a less stable structure, which can be a fracture risk irrespective of density, right? Like just having low trabecular bone score can be a predictor of fracture in itself.
That's exactly right.
Yeah, yeah. Very good. How severe does scoliosis have to be to affect the quality of the DEXA scan?
Well, that's another one. I could talk a whole hour about scoliosis. So a lot of times somebody will say, I have scoliosis. And then I really look at them and they have what I would consider a lateral deviation. So, a scoliosis that is really twisted has a lot of rotation. When bones rotate in the spine, the lower spine, say it's like this, when they take the picture from the front to the back. Now look at all the extra bone that they're going to get. So we don't do bone densities on severe osteoporosis. Now, what degree? For me, it depends on whether or not I can get a clear shot of any of those vertebrae, like a couple of them, without that rotation. And I do get those sometimes. So if I know a case has it, I'm going to have them get X-rays first. X-rays, and I often recommend these anyway. In a severe case, you've got to know if you have fractures in the spine and if whatever other possible anomalies might be in the spine. So, for instance, I will have them take what we call AP and lateral standing X-rays, unless there's some clinical reason they can't stand. Why do I want to do that? Well, I'm a former chiropractor. I'm a big believer in body mechanics. So if I see that the things are tilted or whatever, it's going to help me sort out what might be causing that. Is it from the bottom up or the top down?
Mm-hmm. And that's how they function in real life. I mean, that's what you're seeing, how they have to operate to do normal daily activities is in that standing position.
Yeah.
Yeah. And then you can see where there's going to be excessive forces on the compressive side, on the concave side, right? And then stretching. So finding that balance, that's really important to me to know as well, as looking at how do I design a program that's really going to support this person and not exacerbate that part of the curve and create length where they really need to decompress things.
That's very important.
Yeah.
And I'm a former Iyengar yoga teacher, and we definitely knew about that too.
Mm.
And that's the thing, most doctors today, they don't know zip about exercise or nutrition.
Mm.
They just don't. And I tell people when you go in to see your doctor, know why you're there. You're not there to get nutritional advice.
Mm-hmm.
You're not there to see Dr. Lisa here.
Mm-hmm.
You're there to get what you need, which is typically lab work or something else, but be abundantly clear. And you're not there to talk about the next 20 years of your life.
Mm-hmm.
You're really there to get your diagnosis properly done in terms of lab work. And there's a lot to learn in that area too.
Mm-hmm.
You know, but you're there to get diagnosis.
Right.
And you know, because in fact, today I was in my doctor's group and it was about exercise and the Onera program and, you know, Australia and Belinda Beck and all that regarding how much weight it takes to actually stimulate the bone building aspects of bone.
Mm-hmm.
And swimming isn't going to do that. Walking isn't going to, I mean, they're nice, they're good to do, they're good forms of exercise. They're just not going to really, you know, impact the bone. I don't care how you do them.
Mm-hmm. Yeah, so true. I mean, really that the intensity, and I don't like to say this as having to lift heavy, because heavy has a different connotation, but we have to have effort. There have to be considerable effort and in a way that we're loading our body to do that. As in, we're not just doing something where we could easily do 10 more reps. It's not quite enough effort to create the tension and the tug of the muscle on the bone to do that. Boy, I wish I could have been in your talk today earlier.
Yeah, no, it was really quite good.
Oh,
And you know, I think I mean, we kind of know, you know, like with you know, if you're exercising, say doing 3 reps of something. And these were the early studies, you know, doing like say 8 reps, 3 sets
mm-hmm.
versus 20 reps, 3 sets.
Mm-hmm.
The 8 reps, and you would start with the amount that you could lift. So how much can I lift 8 times with,
Right.
you know, like that? And I know you know this study.
Mm-hmm.
And that third set should be difficult.
Mm-hmm.
And the last 2 should be like, you know,
Mm-hmm.
the 20, the amount that the people were lifting that was 20 pounds, I mean, excuse me, 20 reps.
Yeah.
Did not show the same benefit. It showed the same benefit for muscle,
Mm-hmm.
not bone. So really is that ever, and not everybody can do that. I mean, that's also just a fact, right?
Right. That's true. Yeah. So things should be really tailored to the person. Yeah, there needs to be a little bit of a range and a little bit of adjustment. And that's the thing, people are always looking for that one size, that one recipe, that one fix. But when it comes to lifting at that intensity, there's a path to get there. And it isn't appropriate for everybody. Impact isn't appropriate for everybody.
No.
But we know it's wonderful for building bone density, but not everyone should do impact, that's a whole other conversation as well. You touched on vitamin D, and you said that your thoughts on dosage and vitamin D has changed. Is there a sweet spot, the best that we know anyway, is there a sweet spot of where we want our vitamin D level to be? And is there a reasonably accepted safe dosage?
Okay, there's no safe dosage unless I know what the blood level is.
Right. So you have to have a test.
It's individual. And, you know, last year there was some study that came out, you know, slamming vitamin D testing and saying you don't need it and blah, 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 blah. So most doctors aren't ordering it anymore. And the problem with that, and particularly alternative doctors, a lot of times, they're just giving, they take 10,000 a day or 5,000 a day. And it is a hormone.
Mm-hmm.
And what can happen if you take too much is that it will decrease your parathyroid hormone, and the parathyroid hormone is actually needed to break down old bone. So in the end, you're going to end up with, poor bone quality
Mm.
and density. So it's not, I keep learning, Lisa, that a more balanced approach is appropriate. And where I'm at, and it really kind of depends, but in general, I like to see the blood level around 45 nanograms per milliliters. That's 45 ng/ml.
Hmm.
That's where I like to see it. And that's the typical vitamin D test that we test for our status of vitamin D in the body. It's not the active hormone. Sometimes I test that, especially people with kidney problems. Again, this is complex. This is not super easy, but this part is important to know. Now, what I prefer doing when I test people is I want to test the vitamin D, serum calcium, and the parathyroid.
Hmm.
Because keep in mind, vitamin D is a hormone. It's actually a sacral hormone, which is part of the anabolic grouping of hormones. And just like people think it's willy-nilly, just take a bunch of melatonin, to sleep. I mean, these are hormones.
Hmm.
So I think we have to have a little more thinking on an individual level about, is this okay? Should
Hmm.
we be doing this kind of thing? Now, sometimes, depending on what I get back with the PTH and all that, um, or depending on if they're taking medications, and this is another discussion, but I may lower that vitamin D or I may up the vitamin D. It just kind of depends. And digestion has a lot to do with things like, say, low calcium, but vitamin D increases calcium and phosphorus and magnesium absorption.
Hmm.
Um, and as we can predict, some people are going to be better at that than others.
Hmm.
I've had some people, Lisa, on 1,000 milligrams a day who just for whatever reason, their levels went crazy high.
Hmm.
And I would even have them change the supplement because supplements are not accurate a lot of times.
Hmm.
So we have that going
Many
on.
times, yes.
Yeah,
Yeah.
right, right.
Yeah, I think people really like to just figure that easy fix is to take a supplement. That easy fix is to just say, just tell me how much to take, and I take it without putting it in the context of who they are and that we do have this individual variability. I just really appreciate your message in this balanced and individual approach and testing based approach. And understanding, okay, vitamin D we need for absorption in the gut. It helps to absorb the calcium, the magnesium, the phosphorus in the gut so that we can have that. But too much can interfere with bone remodeling is also what you're saying.
Yes.
When it comes to supplements, I've seen many people be given the 50,000 bolus doses once a week or once a month. But my understanding is it's better to have a more level because it's a hormone than this one bolus dose all at the one.
That hasn't been proven,
Hmm.
but I ascribe to that, thinking that I don't like that idea of giving because it's going to hit all at once. It takes about 4 to 6 weeks to actually convert to the active hormone. I don't see the thing is, if I don't like the idea of it, I've been at this long enough.
Hmm.
It might be true that it's not a good idea. I don't think it's a good idea. I've said that from the beginning. Probably most people are getting this from me from way back. But yeah, I don't like the idea of it. Doesn't make sense to me. The body would never make that much at once, period.
Right.
Wouldn't happen.
Hmm. Excellent. In your 30 years, you just made me think of this. In your 30 years of practice, which clients are you most worried about? Which people made you most concerned? What circumstances?
The anxious ones,
Mm.
the ones that are terrified of medications to the extent that they're fracturing, and they're more terrified of a medication that could actually turn things around
Mm.
than getting more fractures. That
Mm.
that I have patients like that, and I've had a lot of them, Lisa, because people come to me because they see I'm a chiropractor and they think that I'm going to have a magic bullet. I've looked for it for 30 years. There is no magic bullet for everybody.
Okay.
Period. So uh, yeah, it's those are the people who scare me the most because I had one patient, 30 years old, multiple fractures, probably 13 or 14,
Mm.
would not take a medication.
Mm.
So I've seen people die on their sword
Mm.
and be that afraid of science, that afraid of a medication, even after they hear me really sort it out for them. So yeah, they're the scary ones.
Yeah, I appreciate your approach on medications tremendously. And I try to give that balanced voice in this arena as well, because I have seen medications be absolutely life-changing and life-saving for people that, like you say, were already experiencing fractures, and give them quality of life back. Much like I would consider if I needed treatment for cancer, yeah, some chemotherapy drugs have a lot of side effects, but I want the benefit of those medications to help eradicate that cancer. I do think it's important. So thank you. So there is a time and a place for pharmaceuticals. There's a time and a place to look at the options for the medication. We don't need to take a deep dive in here. But what are some of the better medications that you see that are out right now that can help improve bone density and, more importantly, reduce risk of fractures?
Well, highly individual again. Not everybody can take an anabolic.
Mm.
So anabolic means bone building. So they actually stimulate the body. It's not metabolized into the bone. So in other words, they're injections, all of them, but it doesn't get metabolized into the bone. But what it does do is stimulate the bone, osteoclasts and osteoblasts and osteocytes. That's what it does. And further down the line, some of them. So the bisphosphonates, Fosamax, the most common, which is alendronate, and zoledronic acid, which is also reclassed, the popular name. And there's a ton of them out there now, and different names, coming out with different, what do you call it when it's the same thing, but
The generic.
thank you, generic. And then that's one class, and that is metabolized by the bone. They have a longer half-life. And you know what? People trash bisphosphonates. There's a place for them. Prolia is a whole different thing, and it acts very differently. And it's an anti-resorptive. So the bisphosphonates are anti-resorptive. Prolia is an anti-resorptive, which is its real name is denosumab. But it's the most powerful one. So Prolia really, really takes down the bone turnover. The bisphosphonates reclassed among them as the strongest in terms of bringing down the active bone loss, if you will, if there is that. Well, it basically just shuts down osteoclasts. So when our bones are going to be healthy, we need one of my mentors would give the example. Elliot Schwartz. Patients would come in the office and he would slam his foot on the ground real hard. And he'd say, I just damaged some bone there. Now I want my osteoclasts to clean up old bone, to go in there and clean that up. That's what osteoclasts do. They go in and they clean up old damaged bone. Well, if we too successfully or overly suppress bone, it's not going to be good bone.
Right. What is it?
Period.
Quality. Right.
Now, there was a study that was held out for 10 years. So a lot of doctors believe, and even doctors in my doctor's group, well, you can take Prolia for 10 years. So about a month ago, and it's a doctor's group that I'm in, and doctors from all over the world. There's usually about 150 on each call. Endocrinologists, rheumatologists, orthopedic surgeons, and me.
I love it. I love it.
I'm kind of a thorn in the side, but I'm there. And there was a case where a woman had been on bisphosphonates, Fosamax, for 10 freaking years, and on Prolia, and she's fracturing. Nobody says anything about the suppression of that bone. And I'm sitting there going, and then finally, one of the doctors pops in with, hey, everybody, this woman has overly suppressed bones. I was so glad to hear him say that because they would kind of just shine me on, frankly. I'm there to learn, so I don't,
Hmm.
I learn what they have to teach me, but they don't know nutrition. They don't know whatever. And sometimes they're just so overly impressed with the medications that they're not even thinking, my view, basic physiology.
Hmm.
So finally, when he said that, I was so glad that he said it because this poor woman has been, I think it's a lawsuit, as far as I'm concerned, to do that, puts people on a drug that's going to last for on and on and on. And reclass, being the infusion people get each year, is 5 milligrams. Should everybody get 5 milligrams? Should everybody get 70 milligrams of Fosamax? No. 35, half the dose. It's available now. 4 milligrams of the reclass. It depends. I weigh 110 pounds wet. Am I going to take the same amount as a 300-pound person? Again, this goes back to I can't prove exactly what I'm saying, and there'll never be proof because they can't do studies that sort out every freaking thing. So you
Right.
have to use some common sense in this
Yes.
field.
Yeah, exactly. No, I appreciate that, but there is a time and a place. But I see, like, we can't over suppress bone remodeling and
For a long
expect it
period of
for a
time.
long period of time and expect to have the quality of bone to be the same, even though it may be denser. But I just want to circle back to that and talk a little bit about a lot of the people in my group and the work that I've done before is with breast cancer survivors. And they're often offered a medication which they get anxious about taking, but they aren't often taught the context where that medication, usually it's Zometa, can improve their bone density and reduce their risk of recurrence. So it's not just about bone density, but denser bone is less hospitable to distant cancer metastases as
Oh,
well.
no. Yeah, no, they should be taken. Yeah. So uh, breast cancer and using a bisphosphonate would be my choice. There are places for Prolia. I'm not going to get into that now because that's really
Hmm.
much more. I'd have to explain a lot more. And if I only gave a little bit of information, it'd be wrong information.
Hmm.
But for one thing, Prolia is the easiest on the kidneys.
Hmm.
So there's ways to do it, but you have to be way on top of it because if you just stop Prolia, you're at risk for spontaneous fractures in your spine because it suppresses bone so much, then when you go off of it, it's like the bone goes crazy and you lose so much that you start fracturing.
Yeah.
It's rare, but it happens. And I know
I've,
people it's happened to.
I've seen it happen. I've got clients who that's happened to. So this is
Yeah,
public service announcement here. If you're on Prolia, do not just suddenly discontinue Prolia without
ever.
taking
No,
medication.
can't do that. And so Zometa is what's used for people typically with cancer and bone cancers, and or if you're concerned about a metastasis,
Mhm.
or all of a sudden women go into menopause. When they go
Oh, right,
chemotherapy
right.
treatments or whatever, or suppressing estrogen therapies and things like that. And at the very minimum, they should be doing like 35 mil, a low dose of Fosamax. That if they can, now not everybody can, again, all different things. They
Right.
can't all swallow it because if they have GI problems or reflux, I mean, it's all kinds of things. I'm just saying generally
Hmm.
that a half dose, depending on bone turnover markers, which we haven't even talked about, nor could I do justice with, but the treatment becomes looking at bone turnover markers. And bone turnover markers, which is called the CTX or C-telepeptide, and procollagen type 1, which is also called P1NP,
Hmm.
those two I always order. Now, in a case of breast cancer, I'm not going to order the P1NP. They're not going to be, on an anabolic. I can't get way into that right now, but at least the CTX. It's a blood test.
Hmm.
So let's say that CTX, I want to see it around 200. And if it's like 600, okay, the 35 milligrams will probably work if I can work with them with nutrition and exercise and so forth. They'll probably bring it down quite a bit.
Hmm.
Um, Zometa, which is 4 milligrams, so that's better in terms of reclass. That can last, by the way, years.
Hmm.
Many doctors will do reclass or even, well, Zometa often is more frequent doses, but with reclass, which is the more common one, they do a yearly dose. We now know, and this is not just me talking. I'm telling you, we know that some people's bones will stay suppressed for up to 8 years, meaning they don't need to do another dose of reclass.
Mm.
So they just willingly, say, it's easier, Lisa.
Mhm.
Just come in every year, we'll do it. Instead of the individualized work.
Right, right. Thank you. Thank you for that. Um, can we talk a little bit about nutrition? And I would like to know your thoughts on people who follow a pretty strict vegan diet. Is there an increased association of osteoporosis, but more importantly, fractures related to a vegan diet?
I probably, of all the, excuse me, of all the doctors in my doctor's group, I know I've seen more vegans over the years. I live in Berkeley.
Mm.
And again, people come to me because they see me as an alternative doctor. And a lot of alternative people now refer to me as the allopathic chiropractor. That's a big negative thing, right? Because I think I have, as a Buddhist practitioner, mindfulness, I have a balanced point of view.
Mhm.
There's place.
Mhm.
So vegan diets scare the heck out of me, and so do things like the FODMAP diet.
Mm.
Um, it's not that the FODMAP diet isn't needed, but when people go on a highly restrictive diet of any kind, if they don't have a nutritionist to work with them to keep their caloric intake where it needs to be and protein, their bones are going to be, or they're going to lose. And I can just tell you that that happens. Now, the vegan community will throw up some guy who runs marathons and he's a vegan, and there's a woman she's like 85 and she's running. Who does that? These are people who have won the genetic lottery. This isn't you. We can't all do that. And that guy who, runs the marathons and all that, and he's a vegan, I don't know what his bone density is. They just kind of say, oh, look at him. He's never fractured. Well, okay, he won the genetic lottery. I don't know. And probably he eats super well. But I am saying this, that vegans would need to eat an unbelievably stellar diet because from a genetic standpoint, from an evolutionary standpoint, our ancestors weren't vegans. They go over and do the China study, which I can poke holes in all day. And then everyone got all excited about that. Um, but yeah, I'm a big fan of reducing animal intake and eating more vegetarian. Eating, I'm not into four-legged animals personally. I don't recommend that, but fish, some turkey, maybe some chicken. Um, Being careful where you source it,
Mhm.
dairy. And I see people also thinking they have to get all their calcium from food. And now they're just like, eating tons of dairy. That's not good either.
Right. It shouldn't
Being
all be
afraid of
dairy.
any
Right.
kind of supplement. So, there's that part too. So
Yeah.
no, vegan, I've seen a lot of vegan people with horrible bone density and actively losing bone because I test the bone turnover markers. Um, and yeah, that's what happens.
Bone is like 50% protein by mass.
Yeah.
It takes protein for the minerals to attach and for that structure to be strong and flexible. So while a very plant-forward diet is nutritious and we need those plants and we need that fiber and we need that biodiversity in our phytonutrients and micronutrients, yeah, I'm a big believer in how protein can help us build that strong internal structure as well as muscle mass. And yes, I would agree it's possible, but boy, they have to be really, really diligent about getting adequate quality, complete proteins every single day.
Yeah, I haven't seen it. I've been working at this for a long time. I don't see people's bones vegan healthy. I don't. I'm just telling you my personal experience with seeing a
No.
lot of people over the years.
30 years of personal experience. So I
And,
appreciate
a lot of times people go on these restrictive diets because they have disordered eating or disordered eating in the past, anorexia, whatever, or just exercise. I wrote an article, uh, anorexia, well, it's basically anorexia based on exercise. So
it.
some people think, oh, it's just food. No, people become intense exercisers,
Mhm.
and they also are developing a type of anorexia. Anorexia athletica. That's what,
Yeah.
and it's on my website. So, um, I there in our group again, the doctors group, a couple months ago, there was a case that was presented. We do case studies too. where the woman who this doctor was presenting, he mentions right in the beginning, just kind of off the job, where she runs 20 miles a day. A day. So, and he doesn't even go there. He goes on to talking about other conditions she might be. And I'm like, hello, she runs 20 miles a day.
Mm-hmm.
I think there could be a disorder here. And the idea that she's getting enough calories to support 20 miles a day is incredibly hard to imagine.
Yeah. Yeah, I agree completely. Yeah, that excessive exercise with not enough caloric intake, this low energy availability situation that isn't allowing proper repair and recovery. And that we have to be concerned about our young women that are endurance athletes that are having dysregulation in their menstrual cycle, hormone dysregulation when they're in the peak period of time to try to build their peak bone density. So yeah, adequate fuel is a big part of that.
No, and I really believe, and again, this comes from lots of years of, you know, doing work with women. And back in the 90s, I had the menopause center. I don't have a center anymore, by the way, but I did.
Mm.
And we worked with women from all levels. But the biggest thing that I was seeing was the nutritional component
Mhm.
and not really cluing into that, but also understanding. Because people say, oh, and this is me when I was diagnosed with osteoporosis. Oh, how can I eat well? I do all this stuff well.
Mhm.
I didn't do those things well when I was building up the peak bone mass.
Mhm.
So when I was in my teens, I was smoked cigarettes. I did a lot of things.
Mhm.
I still haven't fractured, not, and I haven't started a medication other than low dose estrogen still, but I'm about to because I'm 76
Mhm.
and age drives that. And so now I'm saying, okay, benefits are going to outweigh the risk for me.
Mhm.
So I believe that almost all cases of osteoporosis, of course, there are many that aren't. It can be other things. They could have anorexia at the age of 40, or they could have a digestive problem or whatever.
Mhm.
But a lot of it has to do with they didn't build up a good peak bone mass to begin with. And then if they're a woman and they get to menopause, no one talks to them about they're going to lose 15% likely. And now they have a -4
Mhm.
at the age of 60.
Mhm.
So I believe, and so you have to ask people, well, how did you eat when you were a teenager?
Right.
Because no one's asking them that.
Mhm.
So you want to understand, did they build a good peak bone mass? Because
Right.
I didn't actually lose that much as an adult.
Mhm.
So therefore, I wasn't actively losing. And that's probably, in addition to my TBS being high, meaning bone quality,
Mhm.
that's why I haven't fractured.
Mhm. Yeah, that's part of the big picture and context of who you are and how to assess your skeleton and your bone health. I
Yeah.
love that. I appreciate that very much. And I think that's a good point to wrap up on when we talk about the culture that we grew up in and the diet culture and how to be thin and small and look like some of these images on TV, how incredibly harmful that was. How us taking up less space in the world to please someone's aesthetic look of us is harming us as we are coming into midlife and beyond. And so that's one of my really important messages is give our bodies the fuel we need, build the muscle mass that we can have so we keep doing what we love, like you love, playing pickleball, staying active, traveling, doing what we enjoy, and not having to have our life get smaller so we can stay strong. Thank you so much for joining me today.
Oh, absolutely.
I could ask you 100 more questions, so maybe someday we'll get to do this again.
Yeah, that'd be great. And I'd definitely like to say that, for those of you interested, I know you were going to mention it, but my master class,
Yes.
because I also have a group on Facebook that is Dr. Lonnie's Osteoporosis Myths and Facts.
Mhm.
There's about 10,000 in that group, and people ask questions. You have to be really careful who you listen to.
Mhm.
So I do run these groups because we don't allow any BS in there.
Mhm.
People don't advertise. They don't say, oh, this supplement's going to do that, that kind of noise,
Mhm.
and I think that's really important. And then if you really want to really dig deeper and help protect your physical independence, because it's just still true. There is no osteoporosis specialty. You want to believe who you're going to in terms of your healthcare providers, but I'm telling you, you better have a good understanding yourself. Get my book, really learn about it as much as you can, because they have 15 minutes with you.
Mm-hmm.
And they're just often just going to say, here, take this, do that. Right?
Yeah, couldn't agree more. Empower yourself, gain knowledge so you can have an educated conversation with your provider and gather information that can help you figure out the nuances of your own personal health. Yes, your masterclass is excellent, excellent education. Every Wednesday, I think it's a wonderful, wonderful resource you provide, and your book is invaluable. So thank you again, Dr. Lonnie.
Absolutely. Thank you, Lisa.
Okay, until next time.